Welcome to This Explainer. Today, we're going to completely demystify the wild, incredibly complex, and honestly, kind of overwhelming world of hospital operations and clinical workflows. If you've ever felt lost in the healthcare system or just wondered what exactly goes on behind those swinging double doors, well, you are in the exact right place.
Think about the hospitals you see on TV, right? They're super sleek, ultra-dramatic, and totally paperless. Doctors seem to do literally everything, from taking your temperature to performing complex brain surgery. But do you really know how a real hospital works? The messy, boots-on-the-ground, operational reality of modern medicine is actually way more fascinating, highly interdependent, and vastly different from what we see on our screens.
All right, let's jump into Section 1, Entering the Hospital Maze. How you get into the system.
Okay, let's dive right into this. How do you actually get into the system? Well, it's not always just a dramatic rush through the emergency room doors. There are actually several distinct operational pathways. And here is a massive operational and frankly financial reality that catches a lot of patients totally off guard. There's a huge difference between an inpatient stay and an observation stay. See, when you're officially admitted as an inpatient, the hospital gets paid based on a diagnosis-related group, or DRG. If you're on Medicare, this is covered under Part A. But get this, you could literally be sleeping in a hospital bed, eating hospital food, and receiving round-the-clock nursing care, yet only be classified under an observation stay. That is technically an outpatient status, usually lasting just 23 hours. The billing for that? Completely different. It's based on specific procedure codes, and for Medicare folks, it falls under Part B. That means you could be hit with some serious out-of-pocket deductibles and coinsurance. So, understanding the status, that is step number 1 in advocating for your own healthcare.
Now, what if you're sitting at your doctor's clinic and you urgently need hospital care, say for severe pneumonia? You know what? You don't necessarily have to go sit in a crowded ER waiting room. Hospitals actually employ this crucial operational role known as the shift coordinator. Think of them like the hospital's air traffic controller. Your clinic doctor can just call up the shift coordinator, arrange a direct admit, and boom, you bypass the ER entirely. This kind of quarterbacking role is absolutely vital for keeping hospital operations flowing smoothly and preventing those awful emergency room bottlenecks.
Moving on to Section 2, the Sea of Scrubs. Who's who in the hospital?
So, once you're inside, whether that's through the ER or a direct admit, you are immediately hit with what I like to call the Sea of Scrubs. It can be incredibly confusing because, let's face it, almost everyone looks exactly the same. If a dozen people walk into your room wearing blue and green scrubs, who is actually in charge of what? Well, hospital staff can broadly be categorized into 4 key areas. First, you've got the doctors, the medical staff calling the shots on the overarching treatment plan. Then you have the nurses. They are the absolute backbone of clinical care and continuous monitoring. Next up are the allied health professionals, which includes your physical therapists, ultrasound techs, and respiratory therapists. And finally, you have the indispensable support staff handling facilities, sanitation, and food. Every single one of these folks collaborates to ensure you get successfully treated and back on your feet.
To keep this massive workforce from, constantly stepping on each other's toes, hospitals operate on a really strict model of functional segregation. By firmly dividing tasks into medical, administrative, and support services, hospitals can actually avoid a ton of role confusion. And this isn't just about corporate structure, it's a critical patient safety mechanism. Segregating these duties helps reduce medical errors, drastically improves efficiency, and makes absolutely sure there is clear accountability for every single step of your care process.
Which brings us to Section 3, the chaos of workflow. High-tech medicine meets analog reality.
Even with perfect organizational charts, the minute-to-minute reality on a hospital floor is incredibly complex. On one hand, a modern hospital is a total marvel of 21st century technology. Patient care relies on incredibly advanced systems. We are talking massive electronic health record databases, continuous telemetry beaming your exact heart rhythm straight to a central nursing station, point-of-care bedside ultrasounds, and these deeply complex, evidence-based clinical pathways that guide multidisciplinary care teams. It's pretty wild.
But pull back the curtain, and the operational reality might actually shock you. As Dr. Eric Bricker points out in his analysis of clinical workflows, hospitals are still heavily paper-driven. You'll literally find critical clinical reminders scribbled on Post-it notes and stuck to high-tech monitors. You'll see doctors tied to the wall, using phones with actual curly cords to call different departments. Oh, and yes, the fax machine is somehow still alive and well in the emergency room. It's this fascinating paradox, right? Delivering the highest level of human biological science using office supplies from 1995.
And this brilliantly illustrates why those communication tools, no matter how analog they are absolutely critical. Because the entire hospital workflow is massively interdependent. A doctor simply cannot safely prescribe a treatment until the lab processes the blood work. A surgery literally can't happen until the anesthesiologist clears the patient and the post-op unit actually has an open bed. Even the hospital's billing relies on precise documentation generated by multiple clinical departments all at the same time. It's just one giant interconnected machine.
Let's head into Section 4, Levels of Patient Care. Why nurse ratios matter for your safety.
Navigating this interconnected machine means moving through different floors, which correspond to different levels of patient care. And the defining factor of these levels isn't necessarily the fancy medical equipment, it's the nursing staff. The most vital metric for your safety as a patient is the nurse-to-patient ratio. In the intensive care unit, or ICU, the care is so incredibly complex that one nurse will typically only monitor 2 patients. But once you stabilize and move to a general medical surgical floor, that ratio shifts dramatically. During the day, one nurse might care for 4 patients. At night, when staffing naturally drops, that single nurse might be responsible for 8 patients, or sometimes even more. This ratio is honestly the biggest determinant of how quickly you get help when you push that call button.
Because the jump from the ICU to the general floor is so drastic, hospitals use a really clever operational bridge known as the step-down unit. Think of it as a middle tier of care. Patients here might require highly specific continuous IV medications, like heart rate controllers, that just aren't allowed to be given on a general floor due to strict safety protocols. With a ratio of 3 or 4 patients to 1 nurse, the step-down unit provides a super safe buffer for folks who are too sick for the regular floor, but stable enough that they don't need a highly coveted ICU bed anymore.
All right, Section 5, Demystifying Tubes and Wires. Tools for Therapeutic Intervention.
No matter which floor you land on, let's be honest, one of the most intimidating parts of a hospital stay is waking up surrounded by all that beeping equipment. So let's demystify it a bit. Those wires stuck to a patient's chest? That's telemetry. It lets nurses continuously monitor for dangerous heart arrhythmias from all the way down the hall. If you hear a loud rhythmic whooshing machine, that might be a BiPAP or CPAP machine. It acts almost like a ventilator light. It straps tightly to the face and literally forces oxygen into the lungs to push open fluid-filled airways. That little device often saves patients from needing to be fully intubated in the ICU. And that rolling computer cart with a wand? That's a bedside ultrasound, which doctors heavily rely on today to safely guide needles into veins. Speaking of veins, how you actually receive your medicine is a massive operational decision. The crucial point here is the trade-off between a standard IV and a central or PICC line. See, a standard IV is strictly for short-term use. They're kind of notorious for blowing out or falling out, and you generally can't draw lab blood from them, which means more painful needle sticks for you. A central line, on the other hand, is a long catheter snaked directly into the large vessels near the heart. It is incredibly stable, delivers meds instantly to the central bloodstream, and allows for totally painless blood draws. But because it's a direct highway straight to your heart, it carries a much higher risk of severe bloodstream infections. So doctors have to constantly weigh this operational risk against the patient's actual clinical needs.
This brings us to Section 6, the final handoff, ensuring continuity of care.
Eventually, the goal of all this monitoring and intervention is to get you healthy enough to leave the maze. But leaving is actually a surprisingly complex process. Before you ever walk out that door, the clinical staff has to safely hand off your care, either to an outpatient doctor, a rehab facility, or honestly even just between nursing shifts. To do this without losing any critical details, hospitals rely on a rigid communication framework called SBAR. That stands for Situation, Background, Assessment, and Recommendation. By forcing staff to brief each other using this exact standardized checklist, the hospital ensures that absolutely no life-saving detail about your current condition slips through the cracks during the chaos of a shift change.
So, let's look at how this builds into the actual discharge process itself. You aren't just handed your clothes and pointing to the exit. First, a resident or attending doctor has to synthesize your entire hospital stay into a detailed, documented discharge summary. Then, the nursing staff takes over. They physically hand you this summary, explain all your new medications, and go over your vital lab reports. Finally, hospital administration and social services step in to coordinate your outpatient follow-up. Listen, if this highly choreographed 3-step dance fails, the chances of you bouncing right back into the emergency room completely skyrocket.
At the end of the day, a hospital is not just a building where doctors practice medicine. It's a highly sensitive, incredibly interdependent, and sometimes messy operational machine. From the air traffic control of the shift coordinator, all the way to the critical nurse-to-patient ratios on the floor, every single gear has to turn together. So, I'll leave you with this. How will understanding this machine change how you advocate for yourself or a loved one during your next hospital visit? Because by knowing the rules of the maze, you are instantly better equipped to navigate it. Thank you so much for joining me for this explainer, and remember to always keep asking the right questions.